Welcome to the deep dive. Today, we're jumping into, well, one of the body's most fascinating bits of engineering, the shoulder joint.
The shoulder. Yeah.
It's, this incredible paradox, gives us this amazing freedom, this huge range of motion. Think throwing a ball, reaching way up high.
Or even just scratching your back. Right?
Exactly. But all that freedom, it comes at a serious cost. It makes the shoulder the least stable joint we have. And the most commonly dislocated one, too.
It really is. The classic analogy, and it's a good one, is like a golf ball sitting on a really, really shallow tee. That's your main shoulder joint, the glenohumeral joint.
So for this deep dive, our mission, especially if you're maybe a first-year medical student trying to wrap your head around this, is to give you a clear, memorable, and really actionable understanding.
Yeah, something you can actually use.
We want to look at how it stays stable, how it moves, and inevitably those common injuries that crop up. We're going beyond just memorizing parts.
Right. We want you to get the why. Why is it built this way? Why does it move like that? And crucially, why does it so often run into trouble? Connecting that anatomy to the clinic, that's the goal.
Understanding the structure really unlocks the function and the dysfunction, too.
Precisely.
Okay, so let's start with a question for you, the listener. Think about this. With all that incredible mobility, where do you suspect the shoulder joint is most vulnerable? Like, where's its weak spot, its Achilles heel?
Good question.
Keep that in the back of your mind. We'll definitely circle back to it later on. All right, let's start unpacking this joint. The basics first. It's a ball and socket joint, synovial, specifically the glenohumeral joint.
Yep. The ball is the head of the humerus, your upper arm bone.
And the socket, or maybe the T in our analogy, is the glenoid cavity on the scapula, the shoulder blade.
And both those surfaces where they meet are covered in hyaline cartilage. That's super smooth, almost glassy stuff that lets them glide. Low friction movement.
But you mentioned how shallow that glenoid cavity, the T, is.
Exactly. It's naturally not very deep at all. To give it a little more depth, a bit more of a lip, there's this ring of fiber cartilage around the edge called the glenoid labrum.
Ah, okay, so it tries to make the socket a bit more secure.
It helps, yeah, it deepens it slightly. But the fundamental design choice is still there. Yeah. Prioritize mobility over stability. That's the trade-off. Greatest range of motion of any joint.
But also the least stable, the master of compromise, as you said.
That's it.
So the main bones are the scapula and the humerus, setting the stage for this whole dynamic.
Okay, so why is it so inherently unstable? Let's break that down because it's fundamental.
Yeah, let's list it out.
Well, first, as we keep saying, that glenoid cavity is really shallow, not much of a cup.
Okay.
Second, there's a big size difference. The humeral head, the ball, is quite large compared to the small glenoid cavity it sits on, like a golf ball on a tiny tee.
Right, that mismatch.
Third, it allows for movement in, well, pretty much all directions. Multiplanar movement, that requires looseness.
Makes sense.
And fourth, the joint capsule itself, the fibrous bag around the joint, is naturally quite lax, quite loose, to allow for all that movement.
So the bones themselves don't offer much stability. It's built for movement.
Pretty much, yeah. The bony structure is inherently unstable.
So if the bones aren't doing the heavy lifting for stability, what is? How does the body build this fort, as you put it, to keep things in place?
Right. It needs reinforcements, lots of them. We rely on other structures. Think the joint capsule itself, ligaments, definitely the rotator cuff muscles. They're huge players. And even some other surrounding muscles chip in.
Okay, let's get into those. Starting with the capsule.
Sure. The joint capsule. It's this fibrous sleeve attaching around the glenoid labrum and the edge of the glenoid cavity, and then onto the anatomical neck of the humerus.
But you said it was lax.
It is necessarily so, especially inferiorly. It actually dips down toward the surgical neck of the humerus medially. That extra slack is exactly what allows you to fully abduct your arm, lift it right up.
Ah, so the looseness is functional.
Very functional. But it means the capsule needs help. It's tough, but it can't do it alone. Oh, and there's a little opening in the front, anteriorly, that connects the joint space with the subscapular bursa. We'll come back to bursa.
Okay. And inside the capsule, synovial membrane.
Yep, lining the inside of the capsule and the bone surfaces that aren't covered by cartilage. And here's that interesting detail again. The tendon of the long head of the biceps brachii. It runs right through the joint cavity.
Inside the joint.
Inside the joint, yeah. But it gets its own little tubular sheath of synovial membrane wrapped around it. It's kind of a special case.
Definitely unique. Okay, so capsule, then ligaments. You mentioned those sturdy ropes.
Right, the ligaments. Think of them as static stabilizers, like passive ropes holding things together. We can group them into extracapsular outside the capsule, and intracapsular.
Let's start outside. Extracapsular.
Okay, the big ones here. Probably the most important structure, functionally, is the coracoacromial ligament. It runs between two parts of the scapula, the coracoid process and the acromion.
And that forms an arch?
Exactly. It forms the roof of this protective archway over the top of the shoulder joint, called the coracoacromial arch, or CAA. It's made up of that ligament, the acromion, and the coracoid process.
What does that arch do?
It's crucial. It basically prevents the head of the humerus from popping upwards, superior displacement. And clinically, it's super important because things can get pinched under there. Think painful arc syndrome.
Okay. We'll definitely get back to that. What other external ligaments?
Well, there's the coracohumeral ligament, going from the coracoid process to the humerus, specifically the greater tubercle.
Okay.
Then the coracoclavicular ligament. This one connects the coracoid process to the clavicle, the collarbone. It's actually two parts, the trapezoid and conoid ligaments. And this is the one that tears in an AC joint dislocation.
The shoulder separation people talk about.
That's the one. A tear here separates the clavicle from the scapula. And lastly, there's the transverse humeral ligament. It's a small band that just stretches across the groove on the humerus, the intertubercular groove.
And holds that biceps tendon in place.
Yeah.
The one running through the joint.
Precisely. Keeps it from popping out of its groove.
Got it. So those are outside. What about inside the capsule? Intracapsular ligaments.
Yeah, these are the three glenohumeral ligaments, superior, middle, and inferior. They're basically just thickenings of the fibrous capsule itself on the anterior or front side.
So reinforcements built into the capsule wall.
Kind of like internal buttresses, yeah.
Yeah.
You really only see them clearly if you look inside the joint. They provide some extra strength at the front.
Okay, that's a lot of static structures. Capsule, ligaments, that arch. So back to our castle analogy. We have the walls, the ropes, but what about the dynamic defense? The active guards.
Oh, yes.
What's the strongest, most dynamic system keeping that king, the humeral head, safe on his throne, the glenoid? What do you think, listener? What muscles are constantly working? All right, have you got it? The dynamic defense system. The real MVPs of shoulder stability. It's the rotator cuff muscle.
Absolutely. The core dynamic stabilizers.
And there's that great acronym to remember them, SSC. Super helpful.
It really is. So SITS. Let's break it down.
Go for it.
S is for supraspinatus. This one sits above the spine of the scapula. Its big job is initiating abduction, that first 0 to 15 degrees of lifting your arms sideways. Critical first step.
Okay, initiator and nerve.
Suprascapular nerve carries C5 and C6 roots.
Got it. Next.
I is for infraspinatus. Sits below the spine of the scapula. Its main action is lateral rotation, turning the arm outwards.
Nerve.
Same nerve. Suprascapular nerve, C5, C6. Convenient.
Gary. Okay, two.
T is for teres minor. A smaller muscle, also involved in lateral rotation, just like infraspinatus. And it's a weak adductor, too. Helps bring the arm back in slightly.
And it's nerve.
This one's different. Axillary nerve, also C5, C6. Important nerve, as we'll see.
Okay, and the last S.
The other S is subscapularis. This one is on the front surface of the scapula, the side facing the ribs. It's a powerful medial rotator, turning the arm inwards.
And its nerve supply.
Unique again. It gets innervation from both the upper and lower subscapular nerves.
Wow, okay, so SXEs, supraspinatus, infraspinatus, teres minor, subscapularis. But how exactly do they stabilize the joint? It's not just their individual actions, right?
Not at all. The magic is how they work together. Their tendons actually blend together as they approach the humerus, forming this continuous cuff of tendon tissue.
Ah, the rotator cuff.
Exactly. And this cuff fuses with the actual joint capsule, reinforcing it, particularly on the top, front, and back. But crucially, it's dynamic stabilization.
Meaning?
Meaning the tone in these muscles, even when you're not actively moving, is constantly pulling the humeral head medially, compressing it into the glenoid cavity, like active guy wires holding the ball centered on the T.
Okay, so they actively pull the joint together.
Constantly. And that supraspinatus tendon, remember, passes right under that coracoacromial arch and sits right on top of the subacromial bursa, prime location for getting pinched or irritated.
Setting the stage for problems. Okay, S-sites are the main players. Any other muscles helping out?
Definitely. The big deltoid muscle, the cap of the shoulder, is a powerful abductor, taking over from supraspinatus after about 15 degrees. It adds some stability just by its bulk, too.
Right.
And then you have what some call the splinting effect from the long heads of the biceps and triceps.
How does that work?
Well, the long head of the biceps attaches way up top on the supraclinoid tubercle, just above the glenoid.
Okay.
And the long head of the triceps attaches just below on the infraglenoid tubercle. So they cross the joint, one above, one below, almost like dynamic ligaments or tension bands. helping to resist dislocation, especially anteriorly and inferiorly.
Interesting. So lots of muscles contributing. What about a quick summary of the main movements and who's responsible?
Sure. Flexion, raising arm forward, mainly pectoralis major, clavicular head, and anterior deltoid, also coracobrachialis and biceps. Extension, moving arm back. Latissimus dorsi, teres major, posterior deltoid, triceps, long head. Abduction, lifting arm sideways. Supraspinatus initiates, 0-15 degrees. Deltoid is the powerhouse, 15-90 degrees. And then for full overhead reach, beyond 90 degrees, you need scapular rotation involving serratus anterior and trapezius.
That scapular rotation is key for overhead movement.
Absolutely.
Yeah.
Adduction, bringing arm back to side, pectoralis major, latissimus dorsi, teres major. Medial rotation, turning arm in. Subscapularis is the main one, plus pec major, lat dorsi, teres major, anterior deltoid.
And lateral rotation.
Lateral rotation, turning arm out, infraspinatus and teres minor. That's the basic breakdown.
All right, let's shift gears slightly. We mentioned bursa earlier, these little lubrication packets. Tell us more about the key ones in the shoulder.
Yeah, think of them as anatomical cushions, little fluid-filled sacs designed to reduce friction where tendons or muscles glide over bone or other structures.
Makes sense. Which ones are important here?
Two main ones we need to know about. First, and probably most clinically relevant, is the subacromial bursa.
Okay, where is that?
It sits between the supraspinatus tendon below and the acromion, coracoacromial ligament, and deltoid muscle above, basically right under that coracoacromial arch.
So it helps the supraspinatus tendon glide smoothly under the arch.
Exactly, and also helps the deltoid move over the joint capsule and supraspinatus.
Mm.
But because of its location, it's really prone to getting inflamed, that subacromial bursitis, very common cause of shoulder pain.
I bet. What's the other main one?
The subscapular bursa. This one lies between the subscapularis tendon and the neck of the scapula on the front. It helps that tendon move smoothly.
And you mentioned it connects to the joint.
That's right. It usually communicates directly with the synovial cavity of the glenohumeral joint through that little opening in the anterior capsule we talked about earlier.
Okay, we've built up this picture of a mobile, complex joint with layers of stabilization. Now let's talk about when things go wrong. Remember that first thinking question. Where's the shoulder's Achilles heel?
Ah, yes, the weak spot.
Well, the consensus is, and the anatomy supports it, the joint is weakest inferiorly underneath and also anteriorly at the front. There's less muscular and ligamentous support there.
Especially when the arm is abducted. That position really exposes the weaker inferior part of the capsule.
And this vulnerability combined with trauma often leads to
Glenohumeral joint dislocation. Probably the most dramatic acute shoulder injury.
and it usually dislocates in a specific direction.
Yes. While biomechanically it might start moving inferiorly, it almost always ends up displaced anteriorly and slightly inferiorly. So clinically, we generally call it an anterior dislocation. The head of the humerus slips out of the glenoid and comes to rest, typically under the coracoid process.
What kind of mechanism usually causes this?
It's typically significant trauma, often a fall onto an outstretched hand or a direct blow, particularly when the arm is in that vulnerable position, abducted and externally rotated.
Like bracing for a fall, maybe?
Exactly. Or a forceful throwing motion gone wrong. The force drives the humeral head forward and down, out of the socket. And those powerful adductor muscles can then pull it further into that anterior position.
What are the consequences of a dislocation like that, besides the obvious pain?
Well, it often tears the joint capsule, particularly the anterior part, and can damage the glenoid labrum too, something called a Bankart lesion. It can also injure the rotator cuff tendons.
And that leads to problems down the line.
Often, yes. These structures might not heal perfectly, leaving the shoulder even more unstable and prone to recurrent dislocations, especially in younger active individuals.
How does it look clinically if someone comes in with a suspected dislocation?
It's usually pretty obvious. There's intense pain, and the patient typically holds their injured arm close to their body, supporting it with the other hand. The biggest visual clue is the loss of the normal rounded contour of the shoulder.
It looks different.
Yeah, it looks almost square or flattened because the humeral head isn't in the socket filling out that space. The acromion becomes much more prominent.
Okay. And you mentioned a nerve earlier, something to watch out for.
Absolutely critical. The axillary nerve, C5-C6, it runs quite close to the inferior aspect of the joint capsule and around the surgical neck of the humerus.
So it's vulnerable during a dislocation?
Very vulnerable. It can be stretched or even torn during an anterior dislocation, or also with a fracture of the surgical neck of the humerus, which sometimes happens at the same time.
And if the axillary nerve is damaged, what signs would we look for?
Two key things. First, sensory loss. There's a classic patch of numbness over the lateral aspect of the shoulder overlying the deltoid muscle. It's often called the regimental badge area. Testing sensation there is crucial.
Regimental badge area, good anchor. And motor.
Motor loss affects the deltoid muscle, which the axillary nerve supplies. So the patient loses the ability to abduct the arm beyond the first 15 degrees initiated by supraspinatus.
So they can't lift their arm out to the side?
Right. But a word of caution? In an acute dislocation, testing abduction is incredibly painful and might not be feasible or wise until the joint is reduced. Checking sensation is usually the more immediate diagnostic clue for nerve injury.
Understood. Vital point. Okay, let's pose one last thinking question, staying clinical.
Yep.
Imagine someone comes in, shoulder pain. But here's the catch. It only really hurts when they lift their arms sideways, specifically in the middle part of the movement, say between 60 and 120 degrees.
Ah, the classic arcs.
Yeah, they can start the lift okay, and if they push through, they might get it all the way up without pain at the very top, but that middle range is agony. What structures are likely getting pinched or irritated there? And what do we call that syndrome?
That specific pattern, pain, primarily between 60 and 120 degrees of abduction, is the absolute hallmark of painful arc syndrome.
Okay. And what's getting pinched?
It strongly suggests rotator cuff problems, specifically impingement. What's happening is that structures are getting squeezed in the subacromial space right under that coracoacromial arch.
So under the roof we talked about.
Exactly. Usually it's the supraspinatus tendon and/or the subacromial bursa that are getting compressed between the humeral head below and the arch above during that mid-range of abduction.
Why that specific range?
Because that's when the greater tuberosity of the humerus, where the supraspinatus attaches, passes directly under the acromion and the coracoacromial ligament. Below 60 degrees, there's enough space. Above 120 degrees, the tuberosity has usually cleared the arch. But in that middle zone, crunch.
Ouch. And what does that lead to?
That repetitive rubbing and pinching causes inflammation. So you might get subacromial bursitis, inflammation of the bursa, or supraspinatus tendinitis, inflammation of the tendon. Sometimes the tendon can even develop calcium deposits within it.
If it keeps happening.
Over time, chronic impingement can lead to degeneration of the tendon, weakening it, making it frayed, and eventually it can lead to a partial or even full-thickness rotator cuff tear, usually starting with the supraspinatus.
What makes someone prone to this? Any risk factors?
Oh, definitely. Repetitive overhead activities are a big one. Think swimmers, painters, tennis players, construction workers. Also, aging is a major factor, as tendons naturally degenerate somewhat and their blood supply can become less robust. There's also the fact that the supraspinatus tendon itself has areas of relatively poor blood supply, making it harder to heal from minor damage. And sometimes it's just anatomical variation, and some people naturally have a more hooked or downsloping acromion, narrowing that subacromial space and making impingement more likely.
So painful arc impingement, likely supraspinatus or subacromial bursa, getting squeezed under the arch.
Got it. Now, one quick clarification. You mentioned earlier shoulder separation. That's not the same as a dislocation, right?
Correct. Very important distinction, though commonly confused by the public. Shoulder separation actually refers to an acromioclavicular, AC, joint dislocation or sprain.
So the joint between the acromion part of the scapula and the clavicle collarbone.
Yeah.
Exactly. It involves injury, usually rupture, of the coracoacromial ligaments that hold the clavicle down. The severity varies, but it's damage to the AC joint, not the main glenohumeral ball and socket joint. Visually, you might see the end of the clavicle sticking up.
Different joint, different ligaments, different injury. Good clarification. Wow. Okay, what a deep dive into the shoulder. We've really seen its incredible design, this amazing mobility, but that inherent instability making it, well, vulnerable.
Yeah, central paradox, yeah.
We've highlighted just how crucial those rotator cuff muscles, the SEATs team, are for providing dynamic stability that the bones alone can't offer.
Absolutely key.
We pinpointed that weak spot inferiorly and anteriorly, especially during abduction, which sets the stage for glenohumeral dislocation, and the associated risk to the axillary nerve, remember that regimental badge area.
Vital takeaway.
And we unpacked that classic painful arc syndrome, linking it to impingement under the coracoacromial arch, affecting the supraspinatus and subacromial bursa.
Common clinical presentations stemming directly from the anatomy.
So hopefully, especially for our medical student listeners, connecting those anatomical structures to the clinical picture makes it all click a bit better.
That's the aim. And maybe one final thought to leave you with, something to mull over as you continue learning. We talked about the SITES muscles and their nerves. Think about this. Considering how interconnected stability and mobility are, How might really understanding the precise nerve innervation of each individual rotator cuff muscle actually refine your diagnostic approach, especially when you're faced with subtle weakness rather than complete paralysis?
Differentiating which nerve or nerve root might be involved based on specific muscle weakness.
Exactly. How does knowing, say, that both supraspinatus and infraspinatus share the suprascapular nerve, while teres minor uses the axillary nerve, help you pinpoint the lesion? How does that detailed knowledge empower you to diagnose more accurately and guide treatment more effectively? Something to think about.